What I am showing here is one of my favorite slides, and it comes from a publication. This is a slide that demonstrates kind of the state of our medical care system today and what is described as a reactive medical care system. Here, a patient comes in to the system with an illness at a certain level of disease severity, gets a diagnosis, is put on some type of medication that may or may not work. In this case, it doesn't work. Disease severity increases, medication is switched, still doesn't work, medication is switched again, and so on and so forth. So ultimately, the patient exits the system, may be getting a little bit better, or in fact, the disease state has not changed at all. This is because we don't have very effective means to diagnose diseases. We're primarily treating symptoms. This is a very costly trial and error system. Do you believe that the current medical care system is a reactive care-based system? Okay, so, wow. This is going to be a very easy talk then, because the majority of you believe that it is. So what can we do about it? Our aim is to go the next step, which is to create an efficient medical care system. This is actually even not the optimal. The optimal would be a predictive medical care system, but our next step is an efficient medical care system, where we can actually identify people with disease a lot earlier by some predisposing factors and having screening mechanisms in place, give patients a diagnosis in addition to a prognosis, put them on the right drug the first time, maybe not the first time, but at least the second time, get them when the disease is not as severe. Remember in that previous slide, disease severity was way up here. They get better, and then you have them, you can monitor them over time. Now notice, we don't actually cure the disease, but we've actually improved the life and the care of the individual substantially. This is a much more efficient process because we have screening in place, earlier detection of the disease, more rapid treatment, and improved quality of care, and of course, improved quality of life for the patient. Okay, next question. Do you believe that efficient medical care is possible for CFS and fibromyalgia? 1 is yes, 2 is no. Interesting. Interesting. So I hope by the end of my presentation and also by the end of Ila's, that we will have convinced you that because of identifying biomarkers and really taking an objective scientific approach to CFS, we can actually make CFS an illness that fits right into the efficient medical care paradigm. So I hope to be able to convince that 35%. What do we have now for CFS? We have subjective case definitions that were designed many years ago by the Centers for Disease Control and Prevention and an international working group of physicians and experts from all over the world that put together a definition that was intended for research, not for clinical care. It was intended for research. And again, it's very subjective. It is clinically, you need, in order to get a CFS case diagnosis now, you need to go into the physician, so a clinical evaluation is required, and it requires unexplained, persistent, or relapsing fatigue of at least 6 months duration that is of new or definite onset, and results in substantial reduction in previous levels of activity, plus 4 of these 8. Okay? None of these are required. It can be any 4 of these 8. When the individual meets this criteria, and all medical and psychiatric conditions that could explain their condition are excluded, you are then given the definition or the diagnosis of CFS. And notice that orthostatic intolerance or other orthostatic instability issues are not included in this definition. If we were to apply this case definition to the general population, in fact, what you find is a very large population of unwell, chronically unwell individuals with a number of unexplained illnesses, medically unexplained illnesses, that fit into this definition, okay? So then by definition, this criteria captures a very heterogeneous population of individuals. However, the research definition, the 1994 criteria, has been very effective in helping us enumerate what is going on in the population with CFS and other medically unexplained illnesses. So there are about 4,000 peer-reviewed articles about CFS that have been published and indexed on PubMed by investigators from all over the world. The 94 definition and a few of the variants of the definition have actually allowed us to study the distribution and some of the determinants of illness in specific populations. So we now know that CFS is common, it's highly debilitating, and it affects up to 4 million Americans, and the latest estimates are that it's up to perhaps 17 million worldwide. The risk of developing CFS is greatest in women, although men do get CFS. It's also greater in adults, although children get CFS, but not at high rates. Less than 20% of the people have been diagnosed with CFS, and this is determined by population-based surveys. So of that 4 million people, very few have actually seen a doctor, have gotten the diagnosis of CFS, or are out there in the general population feeling very ill. It has a tremendous economic impact of about $25 billion each year. Remember, this is a chronic illness. People are sick with CFS on average 5 years. Many of them live with CFS for life. And in the patient community, there's this kind of running joke that says CFS is not a death sentence, it's a life sentence. So it's a very debilitating and impacting disease. I want you to note that I'm trying to reference or cite all of the information that I give you. If there is something that's of specific interest, or if you want that particular citation, I have all of these PDFs on my computer so I can give them to you. But I think it's important that we document as much as we can, because evidence is really the documentation of that information. There is also a clinical definition for CFS. This one was developed in 2003 and was published in a journal, I think that was then, it's now a defunct journal, but it was the Journal of CFS. I also have this PDF on my computer if anyone wants it. This is a little bit different, and it was designed for clinicians. This is not a research definition. It was designed for the clinicians to have in their office. It requires post-exertional malaise and/or fatigue, sleep dysfunction, and pain. So in contrast to the research definition that did not require post-exertion malaise, which in reality is the hallmark of CFS, the clinical definition requires it. It also requires 2 or more neurologic, cognitive manifestations, and 1 or more symptoms from 2 of the categories of autonomic, neuroendocrine, and immune manifestations, and the illness has to have persisted for at least 6 months. So you can see from that it's much more stringent than the research criteria, okay? Which makes sense for a clinician. They designed it this way so that a clinician could much more effectively manage the patient on a one-to-one basis. Identify the most severe symptoms, treat the most severe symptoms, and then manage the individual much more effectively. So in I guess it was a year ago, 2 years ago, October of 2008, we implemented a Medscape CME in collaboration with Dr. Bateman, Dr. Lapp, Medscape, and my organization. We designed this Medscape CME to address chronic fatigue syndrome from diagnosis to management, and it was considered a Medscape clinical update. This CME awarded 28,000 credits and 14,000 CMA certificates issued to physicians and providers. Medscape was absolutely blown away by the response of this CME in the healthcare community. They had really almost never seen anything of this magnitude in this little bit of time. Now, the importance, one of the take-home messages for us from this CME was that the most important barrier to the diagnosis and management of CFS patients, and this was after the CMA people had taken their course, they then answered the questions. They said the lack of objective diagnostic criteria and challenges in offering empirically based treatment that often varies from patient to patient was the major block, the major impediment to us getting anywhere with CFS. Sure, we have case definitions. Sure, we can identify these patients with CFS, but help us be able to do something with them and help us objectify the diagnosis so that we can improve the way that we handle the patients and also improve reimbursements, et cetera. This finding was also echoed in a recent survey by the Centers for Disease Control where they surveyed, I think it was about 200,000 docs, and the exact same response came forward. The majority of them recognized that CFS is a very serious and debilitating illness. However, very few know what to do with it when they see it. This is the reason why we need biomarkers, science-based evidence in order to move from a reactive to an efficient medical care system for CFS. So what is science-based medicine? Science follows specific rules to test hypotheses. I think we all know that. And the goal of science, my goal when I'm working in the laboratory, is to ultimately put together information so that I can develop a model of the phenomena that I'm studying, in this case, CFS. So that then we can test that model, we can tweak it, we can change it, we can make predictions about that model to see if what we think is happening or what we're observing in the field is actually fitting the model that we've developed. And if it doesn't, you alter, you modify that model. That is how science works. The science that I'm going to present to you today is a subset, maybe, of the 4,000 articles that have been published. But I've chosen this science because most of it adheres to these rules of science-based medicine. Okay? It's from well-designed studies with the kinds of objective measures that we need in order to make these types of decisions. Okay, a real quick summary of biomarkers. A biomarker is anything that can be measured objectively. And I show this diagram here because biomarkers can vary across the lifespan. You can have biomarkers of treatment, you can have diagnostic biomarkers, you can have genetic biomarkers, and you can also have behavioral biomarkers. So it's very important to understand that there's not likely to be just one biomarker for CFS. There's likely to be a suite of biomarkers for CFS, and they may be specific for diagnosis, they may be specific for treatment.